Last episode, we talked about what happened to the Normals program after the days of the Happy Normals that came over from the Anabaptist churches. The program got bigger as the government funding continued to expand, started recruiting more broadly, stepping away from specific religious groups towards colleges, universities, and unions. But as budgets started to shrink nationwide, the Normals program shrank along with it and started to turn to more hourly patients. Meanwhile, thousands and thousands of research fellows came through the system and conducted all of these different experiments, making it really difficult to judge the value of the Normals program in the 60s and 70s. Laura Stark's book, The Normals, wraps up in the 1980s, right after the death of Bernadette Gilchrist. But the Normals project at NIH continues.
It's revealing that the program changed its name then.
Oh, when did they change their name?
They changed their name right after Bernadette died, and it shifted more towards a public communication kind of vibe. It has now the phrase public liaison in the name, public liaison and patient recruitment program.
So not the Normals or the normal controls anymore.
No more normalcy.
So today, if we were to describe the Normals program, it would kind of be like NIH needs human subjects for various basic research and we compensate them.
Yes. Click here.
Click here.
Yes. You can enroll here. Yep.
Okay. This episode, we're going to check in on what's going on with the Normals today and take a look at the way this program's growth affected human research around the globe and the state of healthy human volunteers today. This online approach really means there are a ton of healthy volunteers out there. And surprisingly, it turned out we had another healthy human subject on the call with us. Kevin, what program are you involved in? What did you sign up for?
Oh, I'm in the All of Us.
Are you?
Yeah.
This is producer Kevin McLean, who signed up for an NIH program long before this podcast project started. It's a sort of big data approach to research where participants are screened and monitored from participating institutions all over the country.
They just sent a message, I think maybe last week, saying that they are discontinuing the tracker portion of it.
That you've
So
been
they're
doing?
not going to give me new Fitbits anymore.
Oh my
Um,
gosh. Oh my gosh.
It's really how they got me in the first place. Although I will say, I did some furious form filling out earlier this morning, and I just got a message saying, "Thank you for emailing the Office of Patient Recruitment at the National Institute of Health.
There you go.
You are now registered as a clinical volunteer."
You're a new normal. This is great. You're a clinical volunteer.
Yes.
You're a normal to me, Kevin.
Yes.
Yeah.
This turned out to be the start of a new clinical volunteer journey for Kevin. But first, we're going to talk about some of the protections for healthy human subjects that are out there today. In order to understand the relationship to what happened with NIH, with the Normals program, and the oversight that is available today, we kind of have to go back in time. Bioethics, from the time of the early Normals, was basically set up by the government researchers. They were reviewing their own protocols. It was very much a trust us kind of perspective. And they expanded that into what are called IRBs, institutional review boards. This is a distributed ethical review system. So they could be at a university, they could be a private company that reviews the ethics and the protocols in place for a research study. That distributed approach has really solidified in the US. A lot of it is due to how the government was doing research with Normals. Laura's first book actually was on how the global IRB system got its start at the NIH Clinical Center. The other framework that people use is the Declaration of Helsinki. It doesn't talk specifically about healthy human subjects, but it's a really important guiding document for many, many countries. The declaration was put together in the 1960s, and the NIH had a lot to say about it.
The Declaration of Helsinki was, of course, an update to the Nuremberg Code. And the reason, to my mind, that it's most interesting was because of what it reveals about the prisoner program at NIH.
They basically didn't want to stop using prisoners, but the European contributors to the Declaration of Helsinki were very hesitant because of what happened during World War II. But the U.S. got its way.
At the same time, the money was coming from the United States.
The Declaration of Helsinki did not include new protections for prisoners, but the U.S. also stopped using prisoners. It became politically taboo.
There was enough political shifting that was happening. This is not something that was sustainable. We need to kind of shut this down. When NIH shut that down for their own research, if it was such an enormous part of research, why didn't research just stop? This is not a problem. We already have the normals program in place.
Meanwhile, the demand for healthy human subjects outside of government research really blew up. The government started to require that drugs from the booming pharmaceutical industry be tested in healthy human subjects as part of the 1962 Food and Drug Amendment.
And those were the rules that, for the first time, said that drugs that went on the market needed to be not only safe, eureka, they also had to work. This idea of safe and effective, and we get the 4-phase system that we have in the present day, which requires tons of people to be healthy human subjects.
One of the big differences between the early days of the normals and now in biomedical research is that these types of trials aren't really being run very often by academic institutions, by government labs, or by hospitals. For the most part, they're often conducted by third-party clinical trial companies, and the oversight is just different. To learn more, we talked with Jill Fisher.
I'm a professor of social medicine at the University of North Carolina in Chapel Hill, and my work has been on healthy people who enroll in clinical trials for money.
Jill wrote a book called Adverse Events: Race, Inequality, and the Testing of New Pharmaceuticals, which was published in 2020.
It essentially kept haunting me that I felt like I needed to do a follow-up project to understand what are these facilities, who's enrolling in them as healthy volunteers, why are they so big, because a lot of these facilities are really massive. And it started out with an ethnographic project where I did observations at 6 of these different facilities.
Jill ended up doing a longer-term study of healthy volunteers just to understand what they thought about the clinical trials they were in and what their experience was like. It was over about a 3-year period.
Some facilities are run in highly professional ways. They're incredibly well-designed spaces that have all the medical equipment that you could possibly need and are comfortable for participants. And others are not that. So when I first started doing this research in 2009, I found that there were some of these for-profit companies that were using reclaimed spaces, like warehouses that they were turning into medical research facilities. One was a crash test site for cars. And so on one hand, that doesn't necessarily sound like it would have to be a bad thing, but what it often means is that they're windowless spaces and spaces that aren't really designed for housing people for longer periods of time.
Beyond the potential harm from the study treatments, there are other health effects to consider.
Participants have talked about how just the fact of doing these studies has made them gain weight, increase their blood pressure because they're much more sedentary than they would be otherwise. That to be in these studies, you're supposed to abstain from exercise and you're given a diet that's often a high-fat diet. And so there's sort of this irony that they want healthy volunteers for the studies, but when you're a healthy volunteer, you're actually kind of living in a somewhat unhealthy manner.
Kevin did not get to be a new normal. He applied to go live at NIH's clinical center in Maryland, but he was rejected.
They were very surprised that I was applying from California. They were like, this is happening in Maryland, right? And I was like, yeah, I can get there. People are wanting to get accepted into things. And so there is also this tension and pressure of you want to present yourself in such a way that you'll get in. For them, it is to get paid. For me, it's because I want to see what NIH looks like and what it's like to live there. I had made it through the initial screening for a couple of studies that were both dietary studies. They are very clear of what the diet is going to be like, but also what the expected activity level is. You're allowed 20 minutes on a stationary bike every day. They asked repeatedly over and over, is that something you're okay with? You can do that. Then they had to ask me about what my typical activity level is. And at the time, I was training for a marathon. So then it sort of flipped to like, are you okay with only doing 20 minutes? I was like, yeah, my race will be done by then. I will be very happy to only do 20 minutes of biking a day. After my last call where they were asking about my activity level over and over, I just stopped hearing from them.
They just didn't think you could
I don't.
cut a sedentary lifestyle.
They didn't tell me explicitly that's how I got cut, but
Yeah.
that did seem to be the indicator.
The Declaration of Helsinki, it got a big update in 2024.
2 words were added regarding healthy volunteers. Quote, "These principles are fundamental to respect for and protection of all research participants, including both patients and healthy volunteers," end quote. This was a big step because the Declaration of Helsinki acts as kind of a foundational document that many countries refer to when writing their own rules and regulations. There were missing elements, however. There's actually a project at France's National Health Institute, INSERM, to codify this more explicitly, called Volrethics. Volrethics, Volrethics. Martin-Enserink, our international news editor, reported on this effort. I talked to Martin about some of the primary concerns and what they think some solutions would be for keeping healthy human subjects healthy and safe.
This French project, they focus really on one segment of people who participate in trials. They're the healthy volunteers, the people who are not doing it because they're sick or expect a medical benefit, but who mostly do it for the money. And who often are in phase 1 trials where you're just testing the safety and the doses of a drug. You're not yet looking at efficacy. And those people have been sort of neglected in trial ethics. You don't read much about them. The French project, well, it's actually an international project, I should say, but they looked at that group and said they're very vulnerable and we need to have better protections for them.
Can you talk a little bit about what makes them so vulnerable?
Especially in the so-called first-in-human studies. The first time a drug goes into humans, there are risks to that because you never know. There could be some side effect that didn't show up in animals. And so it's something that people mostly do for the money because otherwise, why would you, unless you're a very philanthropic person, but most people do it for the money. And many of them do it multiple times. There's just people who've done dozens of studies. So that makes them vulnerable. They're often people who are out of a job or in financial trouble. They're often for minorities. So they have a higher risk and no real benefits except for the money.
What are the main kind of pillars of Volrethics? What are they trying to accomplish?
The people who take part in these studies need to be in safe facilities. They need to be monitored well. There need to be doctors available if something happens. Sometimes the places these trials are done have been abysmal. One of the things they want is sort of long-term follow-up. If people have been in a trial years ago, you could still see after effects later on. With the accumulation of trials, people have done many different studies. They want sort of national registry so that if somebody has just finished another trial or is still in a trial, that they're not jumping into the next one right away, that they have some time for the drugs to leave their body. Few countries have a registry like that. Most don't.
India actually does have a registry for human subjects that clinical trial organizations can consult to see if someone has been in a trial recently or is overlapping. If you're a trial participant, though, you can't check your record or request a transcript. We talked with someone in a unique position to address this. This is Kavya Manoharan. She was a participant in clinical trials. She switched over to becoming involved in their organization and management. And finally, she was recruited into Volrethics.
I'm Kavya from the southern part of India called Chennai. I did my degree in biochemistry and then I thought lab is my only area that kind of work and let me do some research, blah, blah, blah. And that's how I entered.
But she was actually a volunteer in a clinical trial for a COVID vaccine in 2020. She was working in a healthcare setting. She was being exposed to patient samples and she lived with elderly parents.
Were they looking for antibodies or were they testing safety?
Yeah, they were testing for the safety and for the efficacy reason, they were also testing for the antibodies. So they used to do a lot of blood draw and everything.
Kavya actually was trying to help me find more people to talk to that were involved in clinical trials.
When I asked you to help me find participants for the podcast, you said, "Oh, well, they're gonna want money, so that might not work out." So is that kind of your sense of the population there, that if they're going to be in a trial, they're probably going to want some money to motivate them?
You know, when we do a lot of research, just by taking a survey, majority of them participate in the clinical trial not for society, not for their health. It's just for the money.
How was the vaccine trial for you?
In this trial, we had a placebo in the arm, and I was getting a lot of pain, the fevers, everything. And my mom, to the contrast, didn't get anything.
You probably got it, and your mom probably got the placebo, you think?
So with all these things, we were like, we are very sure that I'm getting the vaccine and she's getting the placebo. At one point, the government of India mandated that every citizen need to take up the vaccine, and it was a double-blind trial, unfortunately. So we don't know what we got.
They were mandated to get the vaccine by the government, but because they were in the trial, they only knew they got either a vaccine or a placebo. It was a 50-50 chance.
I approached the site and I said, unfortunately, I need to know what I'm getting.
She had to go back and forth a lot with the trial administrators. They had to go to their sponsors. They came back to her, and she finally got her answer.
Then at one point, they revealed that I was jabbed with the placebo. And my mom received the vaccine. I was very happy that my mom is safe from all kind of viruses, that she got a free vaccine plus all kind of benefits. But at the end of the day, I was like, oh my goodness.
Kavya realized that there were pieces missing in the informed consent document that she had signed, specifically parts about what happens if you get the placebo and suddenly you need to actually be vaccinated and you need to find out. That was missing. Part of her work with Ethics, she was on a committee that looked into how much information to share with participants.
The information about the study to the volunteers. That was my area. I was co-working with a team of 20 with almost 3 to 4 countries.
Her team found that many informed consent documents were filled with jargon, language too difficult for a layperson to understand, and that they needed to make sure that all different parts of the study were explained.
And also in the language that they are very comfortable.
She also found when working with the Ethics committee that, not everything needed to be communicated to the participants.
And what's the way to do it? Does 10,000 people require all this information to be known? Majority of people say, none. I've participated. I've got my money. Please don't call me until there's the next trial.
Kevin did end up getting into a different study, another dietary study, but not at NIH. This one was at UC Davis in California, which is closer to home for him. The study is about nutrient absorption from eating beef, or the health effects from eating beef. So they actually gave him food, and he gets to take it home and eat the same non-meat lunch for 4 weeks, then takes a washout period, and then eats a beef-based lunch for an additional 4 weeks.
The most shocking part was when she gave me the cooler and I was like, oh, wow, this is a lot.
Okay, so how many lunches have you eaten from the cooler since we talked?
I have had 8 lunches. I'm having the non-meat meal now. And the non-meat meal is it takes up a full Tupperware container. It weighs 2 pounds.
Yeah, it's the full, if you ever get to go food, it's filled to the brim. It would spill out.
Yeah.
So day 8, are you still enjoying it, or is it wearing?
There is something about the simplicity of not having to think about what my lunch is going to be. And I already know what it is. And I know that I'm going to be very full.
Looking at it, it just looks like brown.
Are they paying you?
They will pay me, yeah, at the end. I think it's 300 something. I can go back and look.
And they gave you food, Kevin.
2 months worth of food. So I'm so cheap. That's why it's I was like, oh, this is a great deal for me.
You're groceries are getting expensive.
People interested in the well-being of healthy human subjects talk a lot about undue inducement, paying too much money to participate in a trial, or paying a completion bonus that may influence their willingness to stay in the trial. I asked Jill about this, and it turns out institutional review boards are really focused on how much money participants get paid.
IRBs are conventionally very concerned about offering too much money to participants. They're concerned that this will create what's called undue inducement, that people will enroll in studies against their better judgment, or they won't be able to rationally appraise the risks of a study. But I think in the context of healthy volunteer trials, this is really problematic because people are already participating for money.
There's a small amount maybe for altruism, or because maybe a family member has a disease, something like that. There's no medical benefit, like if they were a patient who had a disease. They're just doing it for the money.
So if it's already a financial exchange, I think the concern shouldn't be that it's going to induce people to enroll if you offer too much money, but rather we're exploiting people by unfairly limiting the compensation that people can get, particularly when we think that the pharmaceutical industry is a billion-dollar industry.
One advocate I talked to mentioned, we don't say, oh, we're overpaying firefighters or we're overpaying construction workers. These jobs are very dangerous. If we offer people too much money, they're going to put their lives in danger unnecessarily. And, the IRB's job is to make sure that the research is ethical. So why would the compensation matter if the IRB is already weighing up whether or not this is too dangerous for people to engage in, right?
Yeah, I think that's the fundamental issue here, that the goal of the IRB should be to minimize risk to participants.
Another odd thing about all of this, IRBs can be part of a university or they can be an independent entity, a company hired by a third-party research company to conduct ethical reviews of their research protocols. When the Normals Project first came online and the participants were mainly religious objectors, people who didn't want to serve in war, they were doing alternative service because of their personal beliefs. That did carry some stigma with it, though, with the public, because they considered not serving in the war to be cowardly. Now, today, there's a different kind of stigma associated with participating in research.
I don't personally think somebody should have to be desperate to enroll in medical research for money, but I think there is this sense that if you are doing something like that, if you're selling your body for science, so to speak, that you must be desperate. And so it is stigmatized. And so I think that a lot of times it's not people's first choice. It's not something that they're going to do. Usually they've been doing other things and then they find out about medical research. You also have to take into account that we're looking for people who have the time to spend days or weeks, maybe even months at a research facility. So you're already basically asking for those people to be, if not unemployed, then underemployed, maybe seasonal workers.
Kevin, we really haven't talked a lot about informed consent, despite the fact that that's one of the main things that is supposed to convey the ethics of a study. It's blessed by IRBs, and then it's signed by patients and supposedly thoroughly explained by the people running a clinical trial. What was your experience with that like?
I got all kinds of documentation of what this study is about and what they're going to be doing. They sent it to me in advance for me to review if I wanted to. When I got there for the first screening appointment, the grad student who's running the study, she talked me through every page of the agreement and then just sort of explained both what it says and also in layman's terms what that means. I had time, even after she was done with that, to read through it myself and then, sign.
Jill and I talked through some of the ideas for improvements, like the ones that Martin mentioned from Volrethics and from the update to the Declaration of Helsinki. This idea of a registry came up where people sign up to keep track of their health over time and to make sure they're not double dipping in studies. There's also this idea of getting them signed up with one another in some kind of association that aims to protect research subjects and advocate for them. Kind of like the peace churches and the colleges from the early days of the Normals.
There's a lot of union talk among U.S. participants, some pro-union, some against. I think it's mostly from people who have participated long-term, who see a lot of the problems, and they're kind of committed to this life in some respect, and they do want to see positive change. There have been studies where, let's say, the investigators have changed what's involved in the study. Maybe they've added 4 blood draws. Well, they have to inform the participants and give them the chance to consent again because something has changed. But in some studies, the participants have said, well, look, you've changed what you've asked us to do. You need to pay us more. And when participants are willing to walk, they're going to pay them for those extra blood draws. They will lose more money by not doing it than by giving in. And so participants who've seen the benefits of collective action in that way do see that there are ways that healthy volunteers could band together and improve wages as they see them, improve study conditions.
I know you had a role to play yourself in the Volrethics project. Do you feel like they are paying attention to what you think they need to be paying attention to?
I guess one thing that Volar ethics helps draw attention to that's especially relevant in the US context is that we don't have a good system for compensation for research related injury. So if someone's harmed in a clinical trial, and this is true whether they're a healthy volunteer or a patient, there isn't any federal regulation that requires that those participants are either given medical care or financial compensation for those injuries. That's something I think the Volar Ethics Initiative has also really tried to emphasize, because if you're operating in a country that has socialized medicine, it's maybe not as big of a deal if somebody's harmed in a clinical trial. But in the US, it's very worrisome because you may not have health insurance. You may have completely inadequate health insurance.
Besides banding together with your fellow participants and staging a walkout or calling the police, like what can someone who's participating in one of these studies in the US do to make their voice heard?
Today, there really isn't a mechanism for participants to have recourse if they're unhappy about something that happens in a clinical trial. They can complain to the clinic itself, and depending on their complaints, that ends up getting some people blacklisted. They just won't be invited back, or they won't be allowed to enroll again. So it's pretty risky to participants to actually complain to the clinical facility itself about these things. But the IRB often thinks that these types of complaints are not within their purview.
There's not really a body or an advocate that can take up the cause of a healthy volunteer, unlike back in the time of the normals, when they had the churches or the universities that were coordinating with the NIH. The people who are doing healthy human volunteer research now don't have anyone to play that role. In an ideal world, or, what do you see as a good solution to the lack of oversight and the lack of protections here?
The best case scenario, there would be a research registry, making sure that people were following the rules and that it was enhancing the validity of the study. But at the same time, I think that registry should also be a resource for the participants that are enrolling. What if you were a research participant and you wanted to know, what was that study I participated in 5 years ago, and you didn't save your consent form? Well, there's no way for you to reconstruct that.
So a registry wouldn't just let the clinical trial company say, oh, this person's in a study currently, or they haven't respected the washout period.
A registry should also be a resource to healthy volunteers if we're going to have them, so that you could have essentially a record of what you've participated in and have some level of information about what your clinical trial history was. I think that would be an amazing improvement to the system, and no country is doing anything like that. I think that it would also be really beneficial if there were site inspections of all the facilities that are running these studies. If we can have restaurant inspections, why can't we have clinical research facility? So just the way that animal research is done, I think, provides an excellent example for how it is
I didn't know there
feasible.
were no inspections.
No, there are no inspections at all.
I mean, even mice get inspected. That is shocking.
Again, IRBs are looking at the ethics of these studies, trying to minimize risk to participants, and have never stepped foot in a lot of these facilities. They don't know what the environment is like for healthy volunteers.
Not everything in the early days of the 50s, 60s normals was comfortable. They had lots of needles, LSD, locked wards, but they also had a larger organization advocating for them. That was in the heyday of the program. But what about today's normals? Let's hear from Kevin first. How was your last day of...
Oh, man. I know. Yeah. So yesterday was my last day of what I have started to affectionately call my non-meat slop. I had 28 days of non-meat stew. I am already sort of like a creature of habit, so eating the same thing every day was not terrible to me, but I was very, very glad to be done with it at the end.
But they did take blood from you today.
They did, yeah. I look away when they put the needle in, and then I don't really count the vials. I was thinking about like what my situation is versus like what Kavya had mentioned and what Jill had talked about as well, is like there are a lot of differences for the setup that I've got with this study. I'm not living there. I have the email address. I have the phone number of the people that are running this study. So there isn't like a database or something, but I can contact them. I feel pretty confident that I would be able to get a hold of them.
It's probably something to do with being an academic study.
Yeah, like this study sort of fits in between what we talked about with the normals that were living at NIH versus the kind of industrialized version of normal controls that are at a facility that is run by a private company that Jill was talking about. I'm sort of in this space in between as an academic study where I have probably more information.
After hearing about what normal human subject testing is like today, some of the debates, some of the ways things have changed and others haven't, I went back to Laura Stark to talk about the future of normals. Do you think there's ever a time when we're going to see happy research participants again?
Well, it's interesting. Following newspaper articles around the COVID vaccine trials, I was surprised by how much public exposure of the people's identity was allowed and permissible. And so much of the entire episode of the COVID-19 vaccine trials, because it was this enormous global emergency, there was very much the language around sacrifice the good of humanity. And so the people who were in Seattle in some of the first trials and were healthy people, they were using much of the same language that we saw in the 1950s. It's like, I am so happy to be doing this for the greater good of everyone, and I consider it to be my own good fortune that I get to be of service to other people. It's remarkable.
All we need is a global catastrophe.
Exactly, and that does it.
That's it. That's it. We're almost caught up with the present, except we don't really know what's going on with the renamed Normals Project at NIH. The institutes are cutting programs, there are lawsuits about funding, advisory panels, review panels are being dismissed and reconstituted. For the clinical center, according to some of the reporters here, it's not about the decline in funding so much as many doctors have left and support staff is down, and getting patients from abroad who might be needed to study a rare disease is really difficult. The original normals thought it was a norm for healthy people to sacrifice themselves for science, for the greater good. Later normals thought, let's trade credits, recommendations for the benefit of scientific inquiry. Now, more often, private companies plan the study, private review boards bless the ethics, and the subjects get money. It may be the normal for today, but probably not forever. Looking at 70 years of trying to find what is normal with science, it's easy to see that normalcy is just made up. It's a mean of current conditions. It's a median of what enough people say. It's a limit towards which we approach but never reach. This series was produced and hosted by me, Sarah Crespi. Our supervising producer is Kevin McLean. Audrey Quinn is our story editor. Laura Stark consulted. The Normal series was inspired by Laura's book, The Normals, A People's History of Modern America in 5 Human Experiments. Special thanks to all the very normal people that agreed to talk to us. That includes Jake Eberts. He's a board member of One Day Sooner and a dysentery survivor. Ivy Tillman, she's executive director of Primer, which stands for Public Responsibility in Medicine and Research. And Kathleen O'Grady, a contributing correspondent for Science. Also special thanks to Kelly Cervic, Jocelyn Kaiser, and Megan Cantwell for listening and commenting on drafts. Music for this last episode was by Amity May, Todd Zero, Ivories, and Koki. Thank you for listening.